My name is Connie Sorman, and I am the Senior Manager of Stewardship and Volunteer Development at the Children's Tumor Foundation. Welcome to the February NF2 Meetup. We are really excited about this month's topic and our special guest, who we'll get to in just a minute. I wanted to run through some housekeeping before we get started. As you heard, the meeting is being recorded. Closed captions are available by a live captioner by clicking on the CC button at the bottom of your Zoom screen. And we ask that everyone keep their microphone muted unless you're speaking so that everyone is able to hear the presenters. We also welcome you to introduce yourself in the chat, where you're from and what is your NF connection. We'll have a Q&A at the end of the presentation, but you can put your questions in the chat during the presentation if you like. And then during the Q&A, you can either raise your hand or ask to unmute in the chat, and we will get to your questions. So Salvo LaRosa is our Chief Scientific Officer at the Children's Tumor Foundation, and he is going to introduce our speaker tonight.
Thank you, Connie, and welcome everyone to our regular sessions of NF2 topics. It's my pleasure to introduce you to Dr. Vikram Chakravarthy. Dr. Chakravarthy completed his medical degree at the University of Missouri, Kansas City. He went on to complete his neurological residency training at the Cleveland Clinic. He has completed fellowships in complex spine deformity, Cleveland Clinic, combined orthopedic and neurosurgery, and spinal peripheral nerve oncology at Memorial Sloan Kettering Cancer Center. He joined the Department of Neurological Surgery at the Ohio State University James Comprehensive Cancer Center on September 1, 2022. And his practice is exclusively in spinal and peripheral nerve oncology. So I'm looking forward to your talk, and thank you for joining us. The floor is yours. Thank you.
Wonderful. Thank you, Salvatore and Connie, for the opportunity, and Dr. Danka as well. I'm going to start by just sharing my screen, and then we'll get started. Is everybody able to see the first slide there? Neurofibromatosis type 2 spine manifestations?
Yes. Thank you.
Wonderful. All right. Go ahead and get started. So no disclosures today, but just note there will be some intraoperative images and videos demonstrating both anatomy as well as tumor resection throughout the talk. And so kind of reviewing some objectives. So obviously, based on the panel, obviously you guys know what neurofibromatosis is, but I think just kind of give a little more of a bigger overview. And then comparing both intradural and extramedullary to intramedullary tumors, and how do we define those two spaces within the spinal column? Obviously, we're going to review primarily the spine manifestations in patients with NF2, and also kind of discuss components of an effective spine oncology program. Obviously, neurofibromatosis isn't cancer, but I think in a lot of ways, there's elements of it that get treated, I would say, in a very oncologic, multidisciplinary way. And I think that's something that we really boast here at Ohio State, and I think I would take a moment to share that with you. So just to get started, so intradural spinal cord tumors. So they're a very heterogeneous group of tumors, about 15% of all tumors, and they're located in essentially two different compartments, and it's all in relation to the spinal cord. One is, are they extramedullary, so outside the spinal cord, but within the spinal canal? Or are they intramedullary, so within the spinal cord and within the spinal canal? And sometimes you can also have tumors that are both intramedullary as well as extramedullary. Overall, I would say over the last several decades, the morbidity and mortality that these tumors cause has really come down. And that's really benefited because of early diagnosis with modern imaging, as well as just modern neurosurgical instruments, better microscopes, intraoperative neuromonitoring, and also just improved surgical and radiation techniques. Really, before we get started and really get into the meat of the matter, I think it's important to think about, how do these patients present to us? Most patients are going to present with back pain, but how do we define? I would say you can break up back pain to three categories: biologic, mechanical, and radicular. And each of these is just a little bit different. When we think of biologic pain, this is by and large the most common presentation that happens. And this is night or morning pain that resolves over the course of the day. And this is primarily mediated by steroids or the inflammatory cascade. And that's why typically we treat this pain with steroids, and typically it does get better, but once the offending agent is removed. Other symptoms that patients can present with include motor weakness, paresthesias, myelopathy, maybe sphincter dysfunction. We contrast that to two other pain syndromes. One is mechanical pain. So this is more of a bone pathology or movement-related pain. We can see this sometimes when tumors do grow to quite large size and they start invading bony structures. And based on the location of the pain, the movement is varied. So in the thoracic spine, it's primarily an extension. In the lumbar spine, it's more mechanical radiculopathy. And the third and fourth presentation is myelopathy, where when you have compression that can be both within the spinal cord or outside the spinal cord, compressing it. And this is really what's indicative of high-grade spinal cord compression. And the four main tracts that we see impacted include spinothalamic tract, loss of pinprick, coracospinal tract, loss of motor, posterior columns, loss of proprioception, and then autonomic, bowel and bladder dysfunction. And obviously patients are going to present with all of them, but hints of each of them can really put together a constellation that we know as myelopathy. We contrast myelopathy to radiculopathy. Radiculopathy typically occurs with tumors below L1 or after the spinal cord ends, or when nerves exit the neural foramen. And we really want to differentiate, are these more nerve in origin, bone in origin, and is it within the actual nerve proper, or is it in the nerve plexus? And a lot of that's going to be depending on tumor histology and the degree of tumor extension. And in terms of working these patients up, so we start by just I like to get x-rays because I think it just shows overall alignment and just kind of an overall understanding of global balance. Then typically MRI is really the mainstay treatment of intradural pathology. And although tumors may present in the lumbar spine or the thoracic spine, I think it's important to really get full neural axis imaging, at least at the initial evaluation. CT is helpful. It's primarily helpful when it comes to surgical planning. And it really helps us understand if the tumor is starting to erode or kind of destroy any bone, what does that look like? And the last modality, I think that we don't use it in all cases, but it can be very helpful, is PET scans. And this allows us to determine the actual metabolic activity of tumors. So in patients that have NF1 or NF2, where they have multiple tumors, this can really hint at which one may be the primary pain generator, the primary problem tumor that we should be going after initially. And so before we kind of continue forth, I think it just kind of get everybody oriented. So, when I think of the spine, I think it's we break it up into really three main segments. Everybody knows: cervical, thoracic, and lumbar. And the location of most of these tumors is right here in this vertebral foramen. And so you can notice that the vertebral foramen changes shape as we work our way down. But primarily, if they're intradural, it's going to be within that. And then when we look at this cross-sectional view, you see these little tailed nerve roots coming out, and that's going to be the neural foramen. That's where we think of more foraminal-based tumors. And as I mentioned earlier, so we can really classify tumors into three categories: epidural or extradural, so outside the dura. So this is a nice little schematic of extradural tumors here, really outside the covering of the dura. And these are usually benign tumors or malignant tumors, but they're more bone in origin, or they can also be potentially nerve sheath tumors that are coming out of the actual nerve roots. Or it can be intradural, so within the dura, but outside the spinal cord. And so we can see that both here on an axial section, but also on a sagittal section here. And so when we think of intradural tumors, the extramedullary tumors are primarily things like meningiomas, schwannomas, neurofibromas, versus the intramedullary tumors, they're astrocytomas, ependymomas, cavernomas. You can have Mets as well, but I'd say they're very, very rare. Now, as we continue to break down these categories, looking at extradural versus intradural, and then again on to intradural versus intramedullary. So this is a nice schematic of the intradural tumor that's outside the spinal cord, but here in the intramedullary, it's inside the dura, but actually within the spinal cord itself. And again, when we see it on a sagittal view, we kind of can see here, you have spinal cord around on both sides, but the tumor is running right in the middle. And so as we kind of dive deeper into intradural tumors, we're going to start by kind of focusing primarily on the intradural extramedullary tumors, and then we'll go forth on the intramedullary tumors. So this is going to be about 2/3 of all spinal cord tumors. They're benign generally, they're very slow growing, and usually the symptom onset can be much preceded before patients are actually diagnosed. Oftentimes with long-standing tumors, you can see actually atrophy or thinning of the spinal cord, despite neurologic function being largely preserved. And the symptoms are really going to be based on location and tumor type. So usually with nerve sheath tumors or schwannomas, you see more radicular pain. And with meningiomas, you see more myelopathy or kind of gross spinal cord dysfunction. And optimally, surgery is still really the mainstay of treatment for these pathologies in these patients. And our goal really is for gross total removal. And generally, this is attainable about 90% of patients with a very, very small recurrence rate. And ultimately, when we quote patients on neurologic morbidity, a lot of it has to do with how do they present and how dysfunctioned are they before surgery, because oftentimes that's a surrogate marker for how they will be postoperatively. So think about meningiomas. So meningiomas are, as stated, majority are benign. They're actually going to arise from the endothelium lining, so the lining of the actual of the dura from these cells called arachnoid cap cells. We see it actually more often in females, and really a lot of times it's in the thoracic cavity, the middle part of the spine. They can be located laterally or posterior to the spinal cord, and rarely are they in front of the spinal cord. And oftentimes, if we are unable to get a gross total resection, we can then follow that with imaging studies. And just with the slow growth, it's rare that would cause problems therefore. So here's an MRI scan and a CT scan demonstrating a meningioma. So here you can see this on the sagittal section. It's an intradural, so within the spinal canal, and it is causing private compression. And here on this axial section, this is the actual meningioma. And the spinal cord you can see is very, very pushed all the way into this little small corner. Meningiomas are also interesting because they can have calcifications in them. And so on a CT scan, you can see that calcification or the mixed kind of density here, both in the sagittal, but also on the axial section. And we look at them intraoperatively. This is a nice intraoperative picture of before the meningioma was resected. So you can see the spinal cord is here, really tented up and kind of pushed out of the way with the tumor being present. And then once the surgery is complete and the tumor is resected, the spinal cord kind of relaxes back into view. But largely the amount of atrophy that it's taken over the many years of compression really doesn't change. And so although the function is preserved on imaging studies, the spinal cord may still be the same shape and thickness and caliber. Next, we'll proceed on to the nerve sheath tumors. So those nerve sheath tumors, you can divide them into really, I would say, two varieties. So schwannomas and neurofibromas. And so usually they're going to present as solitary lesions in the 4th or 5th decade. You can have patients present earlier on. And as you guys know, in terms of the genetic syndrome, so three main ones: NF1, NF2, and more recently, what's described as schwannomatosis. And so schwannomas, they're typically going to arise from the dorsal nerve root, so primarily sensory in origin, and they're usually circumscribed from the nerve. Versus neurofibromas, they arise more from the ventral nerve root or motor nerve root, and oftentimes they're fusiform expansions of the nerve. And so you don't see one discrete nerve causing a neurofibroma. It's almost this tangle of nerves that grows into it. And unfortunately, on imaging, typically schwannomas and neurofibromas look pretty similar on MRI. And as we kind of talk about neurofibromatosis, myself being a history buff, I always like to think about where does this all begin. So in 1822, a Scottish surgeon actually was the first to describe neurofibromatosis. He found it in an autopsy study, and he brought it to the Scottish Medical Board. It really wasn't until 1882 where von Recklinghausen, or previously known as von Recklinghausen's disease, actually confirmed the origin of these neuromatous tumors and coined them as neurofibromas. And then about 5 years later was where they actually realized that NF1 and NF2 were two unique genetic disorders and really needed to be treated as unique entities. In terms of how do we get it, I know I'm talking to a consortium that's probably well versed on this, but just to review, there's a two-hit hypothesis. Typically, it's a tumor suppressor gene and a normal gene. So one can be just a sporadic mutation, and then one is where you already have an existing germline mutation leading to a secondary hit or second mutation that then causes progressive tumor formation. So two modalities that can lead to this. When we think about the actual NF spectrum, as mentioned, it's really broken down to three components. So NF1, NF2, and schwannomatosis. As noted, NF1, it's a mix of cafe au lait spots, neurofibromas, the Lisch nodules, optic gliomas, and also can have neurofibromas or even plexiform neurofibromas. And just kind of as we go through one by one, before we NF1 as noted, so it's large plexiform neurofibroma, and that can be both paraspinal in the neural plexus. It can be actually just exiting the spine. So really both entities. And in terms of targets, so we think of, the mutation is primarily originating in chromosome 17. It's the most common spontaneous mutation, autosomal dominant, and it leads to almost 500 mutations in the actual NF1 gene, leading to loss of neurofibromin. And that leads to this RAS GTP pathway being always active. And so unfortunately, that is what stimulates the pro-growth pathways. And so far, we've been able to utilize MEK inhibitors and mTOR inhibitors, and even VEGF inhibitors to try and target patients with NF1. When we think of NF2, so it's a really nice schematic. It's a journal article demonstrating all the various manifestations of NF2. Today, we're really going to focus on the main spine manifestations. So spine meningiomas, schwannomas, and ependymomas, and kind of look at them more in close. NF2 is also sometimes referred to as MISME, because although it's called neurofibromatosis, rarely are neurofibromas actually found. And so MISME is kind of the acronym for multiple inherited schwannomas, meningiomas, and ependymomas. Again, it comes from chromosome 22, and the gene is called Merlin. It's a loss of Merlin, and it actually leads to increased signaling of the ERB-B EGFR pathways. And currently, kind of active targets that we're working on include the mTOR, VEGF, EGFR, and PGF pathways. And the challenge here with NF2 is that there's often mosaicism. So, we see patients with, I'd say, almost an incomplete NF2 where they have fewer tumors and it's actually a better prognosis. But this too makes NF2 a little more challenging than treating NF1. As mentioned, schwannomatosis is this third entity, and really it came to be in the late 90s and really was better defined in 2006. And primarily, these are patients that have spine and peripheral nerve tumors and really no cranial tumors. And this too is genetically mediated by two genes, so SMARCB1 as well as LZTR1. And the risk of MPNST is very, very low. There is phenotypic overlap between NF2 and NF3. And again, just like the other entities, typically we start with full spine imaging and utilize that to kind of guide therapy. And ultimately, what is the natural history? So schwannomas typically are large. When they're large and extramedullary tumors, they're likely to progress if patients have NF2, but if they do not, usually they're very slow growth. And we really see three main growth patterns. So one is no change in size, two is continuous slight growth, and three is initial growth followed by rapid growth. And the challenge is we don't know when they present who's going to proceed in which direction. And so oftentimes we do follow patients with imaging studies because we don't have a good way of being able to predict the natural history. For completeness, I do want to touch base on MPNST. It is something that I think we worry about in patients with NF1 and neurofibromas, because they can, about 10% of them can become aggressive and turn into an MPNST. But aside from them, it's a very small portion of the entity. 6% of all intradural tumors. Microscopically, they're very cellular, spindle shaped, and they truly are sarcomas. And really, when we think about surgery and the role of resection, it can be challenging. Oftentimes, these are they're treated like sarcomas. They're infiltrative, they're invasive, and really being able to get a gross total margin negative tumor resection is quite challenging. So this becomes a very delicate conversation with patients as to what is the best course of proceeding. Now, as we progress, so ependymomas are kind of the first intramedullary tumors, and there's really two main varieties. One are the myxopapillary ependymomas, and so these are ones that actually are technically, you can call them extramedullary. They're they usually you find them at the bottom of the spinal cord, right where the spinal cord goes into the lumbar nerve roots or the cauda equina. These are going to be the patients are going to present with back pain, sphincter dysfunction, and the challenge with these is oftentimes patients are presenting with metastases at the time of initial tumor presentation. And although it may not have been noted, looking back on older studies, you can usually note that. The actual spinal ependymoma or intramedullary ependymoma we see, those are more higher grades, grade 2s and grade 3s, and those are actually within the spinal canal proper. And so they typically are a tumor with an associated cyst that's also present. And usually the cyst is actually a tumor-induced cyst or tumor-formed cyst. Ultimately, gross total resection is the treatment of choice. And in patients that aren't able to achieve gross total, oftentimes they're treated with postoperative radiation. And so this, we're going to compare and contrast them. So this is a myxopapillary ependymoma. So as noted, this happens at the bottom of the spinal cord, around the levels of L1 or L2. And you can see it almost has an appearance like a schwannoma, which I'll show. And this is a picture of it actually resected versus an intramedullary ependymoma. So this is actually within the spinal canal, within the spinal cord itself, actually. And here you can see the spinal cord is really stretched and draped. And we've actually made a small opening in the spinal cord to access this tumor. And now the tumor's been resected, we've got a nice large cavity here once the tumor's been removed. And so next, I want to kind of focus on the surgical management and really kind of take you guys a little bit through the steps of how do we do the surgery and ultimately how do we do it safely. Before we talk about the surgery, it's very important to understand what are our goals. And our goals, especially when it comes to NF1, NF2, and Schwannomatosis, it's very much symptom oriented. And our number one goal is to preserve neurologic function. And as surgeons, we're very good at local tumor control. We don't really have much impact on systemic disease control, but really we can be the champions of local tumor control. So pain relief is another big factor. And ultimately, as a surgeon, my own philosophy is to improve quality of life. And so how can we do a small operation to really provide a dynamic improvement in people's quality of lives? And ultimately, we want to show that there's documented growth on repeat imaging studies. And if we have patients where there's multiple tumors, can we demonstrate that one is maybe more metabolically active than others? So now really we'll go through these steps. So how do we do it? So most patients are positioned prone, so they're on their belly. We always typically go from the back, a posterior base approach with a midline incision. We do what we call a laminectomy, which is removing the actual bone. So here's kind of our corridor. We take actually the bone, so you can notice that there's bone that is basically in the way to get to the spinal cord with good hemostasis. So we use things like high-speed drills to get down to the actual dura or the covering of the spinal cord. So high-speed drills. Next, once we get the bone off, this is what we're looking at. So we're looking at essentially the spinal cord, but it's covered. So it's covered in the dura, or the covering of the spinal cord. And we usually bring in our intraoperative ultrasound. The ultrasound is very helpful because it shows us, have we gotten enough bony exposure? And so we ultimately want to make sure that we have good margins above the tumor and good margin below the tumor so that when we open the dura, it's right where the tumor is. And you can see here with 3 different tumors, it looks different inside with an ultrasound. So here's an ependymoma, and you can see because an ependymoma is actually within the spinal cord itself, you see that these are the borders of the spinal cord and it's nice and dilated. And on an axial view, it's a nice dilated spinal cord. Versus a meningioma and a schwannoma, these are extramedullary tumors. So a schwannoma, you can see it's coming off the actual surface of the dura, and the spinal cord is kind of pushed off to one side. Versus a schwannoma, here you can see the actual spinal cord here, though within the dura, we have this large tumor kind of pushing extrinsically or pushing on the spinal cord. So this is really interesting because in cases where we may not be certain as to what the pathology is, this can maybe give us a hint. And so when we open the dura, video here, so we open the dura really with a sharp blade. And so again, it's kind of really taking your time, being delicate, and making sure that, so the dura has multiple layers, but using nice dissection, and we really want to cut layer by layer because oftentimes either right below us is the tumor, or even not, or even the spinal cord, depending on how full that spinal cord is. And you'll see here, we're just kind of taking our time, kind of layer by layer, really not in a hurry. And then when we're able to get enough of an opening, we can actually put an instrument, what we call a Woodson elevator, you can see kind of sticking into there. So we're kind of dissecting free underneath. And then we'll ultimately use that to protect the spinal cord deep to us and then run the knife over top of it. So I'll just give the video here a moment to play. And our ultimate goal is, as we open, is really to open in a controlled fashion. We don't want to release spinal fluid too quickly because that can also lead to unnecessary bleeding or just increased pressure. But really, it's just kind of very gentle, and ultimately everything has to be in control. And another thing you notice in this field, everything has to be dry. We really want to make sure there's no bleeding, the whole field is dry, because ultimately we don't want that blood to rush into the spinal canal, because that can lead to post-operative complications, things like headaches, meningitis. And so we just kind of used, exactly, just to kind of guide us all the way down this opening. All right. So once we have the dura opened, so then we tack it up. So we use little stitches here to tack it up. And The next few pictures are going to be actually what do these tumors look like when we open the dura. And so this is actually what a schwannoma looks like. So you can see it's kind of this gelatinous entity that it's very much separate from the spinal cord. So this is our actual spinal cord proper. And we know that because there's actual vessels on the surface of the spinal cord. Versus here is the actual schwannoma, and it's this kind of gelatinous. It'll have a lot of these arachnoid adhesions on it, so these kind of wispy white collections on it. And really our goal is kind of manipulate the schwannoma and try and find where's that root of origin. Oftentimes, depending on the location, if it's in the neck, the cervical spine, or the lumbar spine, we'll use a nerve stimulator to stimulate the nerve to make sure that it's truly not a motor root. In terms of the pathology, so this is what a schwannoma looks like under a pathologic slide. So they'll primarily stain with S100 positive, and this is what a pathology slide of a schwannoma looks like. This next one is a meningioma. So again, so here's the spinal cord here, and you can see it's really draped and pushed over. And this is really the meningioma here. It's very dense, it's very bulky. It can actually be calcified in origin and really thick and kind of almost rubbery. And so we really have to be kind of delicate in terms of manipulating the meningioma. And oftentimes the meningioma can be attached or tethered to the spinal cord. And so these tumors are not ones in which you can really pull and move out of the way. Oftentimes we have to take our time, debulk it, shrink them down. And as they get smaller and smaller, then we're able to manipulate it more and more. And really the goal here is to protect the spinal cord really at all costs. And so to contrast here to the schwannoma, this is a pathology side of meningioma. And so the main stains are going to be EMA and Vimentin. So you can see there's obviously a lot of varieties from meningiomas, and this is really what one of them looks like. So next I want to kind of show a little bit about how do we do intramedullary surgery. So actually taking out tumors within the spinal cord itself. And so these, of course, are a little bit more challenging and actually I would say a lot more dangerous. The spinal cord, unlike the brain, for example, really is not very forgiving, and it doesn't really have an area where it's non-functional. And so oftentimes when you see a spinal cord tumor, these spinal cords are swollen, they're engorged, and it's very difficult to tell where the midline is. And it's very important to open the spinal cord in the midline because that really minimizes dorsal column dysfunction, or really that kind of postoperative numbness, tingling that can happen. And so we're looking for this thing called the midline raphe. And so we follow the veins, follow the vessels on the back of the spinal cord, looking to see where do they come close to the midline. And so even in a swollen cord, we can locate that, and that's ultimately where we're going to make our opening. And so here's kind of another an ependymoma. And so here you can see the MRI. Here's the ultrasound. And again, so we've started with this the spinal cord, and we've made our opening really along that vein, along the vessel. And our goal really is to any really larger vessels that we see on the spinal cord to preserve it really at all costs. And so letter D is now the tumor's out. Now we've got a little central cavity here formed. And so this is what ependymomas look like. So they have some elements of meningioma and schwannoma staining, but they obviously look very different. They have these pseudo rosette patterns, both perivascular, so around blood vessels, as well as ependymal true rosettes. And then so once we finish the surgery, we take the tumor out, we send it off to the pathologist, we get confirmation from the pathologist of what it is. Then it's really time to close the dura. So it's extremely important to close the dura, or the covering of the spinal cord, in really a watertight fashion. And we can do it in one of two ways. One, we can just use stitches. And so this is just kind of a running stitch that we do. The other is we can also use a dural stapler or these clips, and these clips kind of bring it together. And so this ultimately our goal is one is to obviously take the tumor out safely, but two is to really minimize any risk of spinal fluid leak postoperatively. And so once we do this, while the patient's under anesthesia, we have them bear down, or through the anesthesiologist, we have them kind of hold their breath and induce almost a Valsalva maneuver, and to kind of check and see are there any gaps that are causing spinal fluid leaks. And then we spray down a kind of gelatinous glue over the suture line just to make sure that we really get a secondary bolstering hold to minimize those leaks. As mentioned, the morbidity and mortality of spinal cord and spinal canal surgery has really improved over the years. And a lot of that has to do with the better tools that we use. Things like the microscope, micro instruments, using the intraoperative ultrasound as mentioned. And really, I think what's really helped us out a lot is neuromonitoring. We use really strong invasive neuromonitoring. We work very closely with technologists that are monitoring sensory potentials, motor potentials. And when we're doing surgery within the spinal cord, we're actually able to monitor motor potentials while we're taking out a tumor. And that's really what this innovative monitoring called D-Wave. And so these are a couple graphs of just, the top graph is more of a sensory monitor, what the sensory potentials look like during surgery. And the bottom one here is a motor one, looking at motor potentials during surgery. And then this is a D-Wave. So D-Wave is very interesting. These actually, we put the electrodes inside the dura, one towards the head, one towards the feet. And so what that's doing is while we're working within the spinal cord, taking out the tumor, it's capturing potentials that are going around the tumor from the head to the feet. And so while we're doing that resection, we know that we're not harming the patient during that procedure. Now, surgical resection, depending on the tumor, is actually taken on more and more innovation. And so depending on where the tumor grows, if we have tumors in the presacral area, or next I'll show you a retropleural area, these tumors before were really accessed through large midline incisions, big exposure through the abdomen, but now we're able to use things like the Da Vinci robot, where we make multiple small incisions in the belly, maybe one little bit larger incision for the tumor to come out with much less morbidity, and patients are able to go home much earlier. And so this was really a great option for both young and old patients, because just with limited surgical morbidity. And so this is a case of the Da Vinci robot where we're doing it for a retropleural tumor, and we're able to do a lot of the similar adjuncts that we can do in open surgery. We can bring in a nerve stimulator. We're able to use cautery to kind of cut and be more fine and gentle. And this is really, I would say, has, depending on the location of the tumor, has really minimized the surgical morbidity and made these tumors much more accessible with better patient outcomes. There are physicians out there that are doing these tumors through more minimally invasive approaches. In my practice, I typically don't. I think they're a little bit more risky. But here's a large series of patients that had tumors through a more minimally invasive approach. And the way these are done is usually through an expandable tube. And this is a series of people who had meningiomas or schwannomas. And as noted, there were complications, including spinal fluid leak and new deficits. There are a couple of anecdotal reports out there of people using the endoscope for surgery. I would say in my experience and kind of in my own philosophy, I think really to protect the spinal cord, it's just much safer to do it from a more open, visually appreciative approach versus a more minimally invasive approach. Maybe a little bit bigger incision, but just a, let's say, safer operation. Post-operatively, how do we follow these patients? So typically, as noted, we can see them on MRI. We get a baseline MRI at the time of diagnosis, and then we typically repeat that MRI for positive findings at 3 months, and then annually. And post-operatively, once we complete the surgery, we'll typically do a repeat MRI at 3 months. And typically, and I would say for patients with NF2 who don't have any spine schwannomas, I don't think there's a role for any surveillance MRIs. And then the literature will also agree to that as well. And typically we'll obtain imaging based on symptoms, not prophylactically. We do here at Ohio State, we do next-gen sequencing on all of our tumors, where we send them out for additional somatic gene mutations. So on top of the known genetic predisposition syndromes, we can also see if there are other somatic gene mutations that may be contributory to these tumors. And just for completeness, we talked about the surgical approach. I just want to touch base, highlight a little bit about both targeted therapy, but also radiation before we kind of close up here today. So what is targeted therapy? So targeted therapy is cancer treatment that targets proteins and control how cancer cells grow, divide, or spread. And in this case, it's, I would say equally applicable to NF1, NF2, and there are MEK inhibitors called like brigatinib. And then there is one trial from Recursion Pharmaceuticals called the REC-2282, which targets NF2 mutated meningiomas. I think these are primarily for cranial or brain meningiomas, but they can also be used for spine meningiomas. There is one kind of big clinical trial that's out there. It's a prospective registry called Intuit NF2 trial, looking at either brigatinib or neratinib. And the interesting thing is they're actually able to utilize essentially 2 drugs in one study. It's a phase 2 trial looking for 80 participants. So actually, it's a big collaboration with the Children's Tumor Foundation. So kudos to them. And then really, is there a role for RT? We know that radiation is out there, but how much can it be applied to this population? Just from a big picture standpoint, so there's two main types of radiation. One is more conventional or large field radiation, and the other kind is stereotactic or highly precise radiation. Conventional radiation typically is not used for schwannomas. This is more for epidural disease or metastatic disease versus stereotactic radiation, which is really where it's the majority of radiation is now shifted towards, is highly precise, single fraction, and allows us to preserve healthy tissue. And so it allows us to really isolate the actual tumor that we're treating and preserve the healthy tissue around it. And this is something that we do use for schwannomas on a kind of case-by-case basis. And when we compare, there's a lot of, when we compare both stereotactic radiosurgery, which is done through photons, and proton beam radiosurgery, which is done through protons, there is some small differences. So photons are obviously small packets of high energy light, versus protons are tiny particles from the center of atoms. I'd say the one benefit of protons is that you really have a steep dose drop off outside the tumor volume. And so that's nice, because if you have areas that are very delicate and you really want to make sure to contour, minimizing dose to things like the spinal cord, other critical brain structures, that's where I think protons are valuable. Otherwise, I think photons are equally valuable and equally beneficial. Just a couple of very quick studies on, schwannomas. There two big studies. One came out of Pittsburgh and out of Gerson's group, and one was Sokdev's group. And looking at 35 patients, small percentage had NF1, a smaller had NF2, but they were, all these tumors were treated with no long-term spinal cord complications. But then we always worry, the risk of malignant transformation. And I think we just haven't, there just isn't a volume to really have a platform statement on that. But I think really things have to be addressed in a case-by-case basis. And kind of as we close up today, we started in a world like this where we have surgery, targeted therapy, and radiation as three separate entities. And as we continue to learn more and more about NF1, NF2, and various targeted therapies, we're really going to come more and more to a closer harmonious balance. And as surgeons, our goal is to really balance these three out in a multidisciplinary fashion with the use of both radiation oncologists, neuro-oncologists, and spine surgeons. So I look forward to kind of working in our multidisciplinary team and continue to grow our program here. Thank you again.
Okay, well, we have some questions, so we can kind of tell you what those are. Let me go back up to the top.
And maybe I can say a few words. So Vikram, thank you very much. This was, I looked at your slides. You kindly shared those with us today, and for us who deal with the intracranial lesions, this is really new territory for us. Usually we don't really interact that much, other than that we send patients one way or the other, right? So I think it's just great to hear your perspective, and I think it's just an important topic with NF2 when we discussed it, because everyone talks about acoustic tumors and meningiomas basically in the skull, but I think a lot of folks with NF2 really struggle with what to do with the spinal tumors. So I think your expertise is just really critical here. But I don't want to belabor this much further. Really enjoyed listening to you, and I think we had quite a few questions from the audience, right?
We do. All right. So the first one was from, I just had it and I lost it. Okay. It's from Ariana Solis, and it's, if a patient has an ependymoma in C4, C5, and schwannoma in the same area, can both tumors be removed at the same time?
They can. It's definitely a bigger operation. I think the challenge is probably between those two tumors, really trying to discern which one is causing the problems and seeing which one can be tailored. They definitely can, though.
Okay. This one was from Susan Bono. And what is your experience in the probability of regrowth of a resected intramedullary ependymoma, and how often are they associated with an attached syrinx?
So ependymomas they can have a searing. Usually it's more of a cyst cavity that is actually from the secretions of the tumor. And if there's a gross total resection of an ependymoma, it's rare that it would recur. Sometimes there can be kind of an existing, whether you call it searings or kind of cyst cavity that's always there persistently postoperatively. And those usually don't, at least in my experience, they usually don't regrow as tumors, but there'll always be imaging findings on future imaging studies.
Right. And Stephen asked regarding intradural and extradural spinal tumors, which is easier to remove? First question.
Easier, I would say they both offer different challenges. I think it's always easier not to have the spinal cord in the field that you're working in, just because it's safer. Personally, I enjoy probably taking out intradural tumors more, but they both have their own challenges.
And then a follow-up is, can you reliably tell what type of tumor you are dealing with pre-surgery using imaging?
Yes and no. I think so. Most tumors, yes, you can. I think as surgeons, I'm always coy to give that away because we've always been fooled, and it's better to kind of give a broad differential and be glad that our hunch was met versus promise and realize that it was a different tumor.
And his last question is, which leads to more surgical complications and thus a harder recovery? I've heard from neurosurgeon that recovery becomes much harder when you open the dura. Not sure if this also is true for the spine.
Yeah, so I think with each, the deeper you open the spine, so if it's extradural, I would say the recovery is easier and it becomes more difficult as you go deeper. So if you open the dura, it's a little bit more difficult than not opening the dura. And definitely if you open the spinal cord, it's going to be more recovery than just opening the dura.
All right. From Roland, can you remove several tumors during one surgery? That's similar to their previous question.
You can, sometimes whether it's people with NF2 or NF3 schwannomatosis, sometimes you do have multiple contiguous schwannomas and they're all kind of lined up one after the other. And you definitely can, if it's all within the same exposure, take out multiple tumors safely.
And those were all the questions I saw. Did you see any others, Michelle?
I did not actually.
Okay. If anyone has a question that they'd like to ask now?
Oh, there is one from Bridget Ovison. Is there an average age for ependymoma resection?
We see it mainly, we see it present oftentimes in this kind of 25 or 30 to 40-year-olds, but it's usually kind of on the younger end of the spectrum.
Interesting.
And there's a lot of comments saying thank you for being so proactive and making a difference and for sharing your knowledge. Thank you to CTF. And we've had a few people asking about when the recording will be available, and we'll make sure that it's sent out by the end of the week. So
if anyone else has a question, you can unmute yourself and ask or raise your hand, whatever you're most comfortable with.
I have a question. This is Michelle from CTF. So you were talking about the radiation, and I will admit I was having a side conversation with my colleague Connie, because I know Gareth Evans from Manchester says that the research would say no to any type of radiation. So can you explain a little bit? You're talking about like the proton beam more targeted would actually be okay for NF2 patients because it's direct to the tumor and doesn't affect the outlying areas?
I think in NF2 specifically, I think definitely I would limit or avoid radiation options. I kind of meant to show that just to kind of be complete. I think typically surgery is the mainstay. Oftentimes, if there is a small residual, it can be followed. But I would say surgery and surgical resection is usually the mainstay.
And then I have one follow-on question. it's come up a few times, and maybe Salvo, you can help me with this question too, but do you find that if somebody does treatment before they do surgery, that it changes the tumor at all, or there other tumors that may grow? I've been hearing that a little bit, and I may not be making sense as a layperson, but hopefully, maybe Salvo, you can expand upon that question too.
Yeah, I guess the question Michelle is trying to get to is sometimes with targeted therapy or chemotherapy, the biology of the tumor changes, and that may also affect the surgery that is going to be made on those tumors, and it can be preoperative or postoperative. Can you comment on those?
Yeah, I think definitely adjuvant or preoperative treatments can change tumors. Sometimes it makes them more firm, more adherent. And I think just as a surgeon going in, anytime there's been preoperative therapies, I always kind of approach it with more caution, just in the off chance. It's not, I don't think the same effects we see as we do as much in the brain with tumors, but I would say similarly that can happen.
Okay.
And maybe just one comment, because we see that question quite a few times with regards to acoustic tumors and meningiomas in the brain, right? And I would echo what you just said, Vikram, that we try to avoid it whenever possible. That being said, on folks who are a little older, we would sometimes consider it. I think I would caution for acoustic tumors that it's sometimes, used or marketed as some kind of form for hearing preservation, and we just don't agree with that, right? So I think, but certainly a very common question for us,
Oh, go ahead. Was somebody gonna? Is that you, Connie?
It is me. So let's see. Mike Ashley asked if it's possible for tumors in the SI joint with NF2.
It won't be necessarily in the joint, actually, in the joint proper. It could be in the sciatic nerve or the sciatic notch, but not necessarily in the joint. So.
And then a couple of people have asked if you would be willing to share your contact information so that they could follow up with you offline.
Sure. Yeah. Maybe Connie, I'll just send you my contact information. You're welcome to share that.
I can send it out with the recording and the slides if that's okay with you.
It is.
That'd be great.
It's actually
you're on the screen, right?
Yeah.
We've had this for some of when I gave talks previously. We usually just shared my email, and then folks can contact us, and we can set up virtual appointments, etc., via that mechanism. So.
Yeah, love to help out.
And there's one other question in the chat. When do you make the decision to do a spinal surgery? That's from Roland Toms.
I think a lot of it. It's a few different things. One is obviously trying to figure out how much does it impact quality of life. 2 is understanding what is the tumor's relationship to the spinal cord and what symptoms are being presenting with. And then 3, obviously taking into consideration the patient's wishes and kind of working with them to understand, do they want it? Are they ready for it? And ultimately making that decision together.
Hopefully, Roland, that answered your question. Yeah.
Well, we are so grateful to have had you on the meeting tonight. Thank you so much. Just a few wrap up things that I would like to bring up. So if you indicated in our registration form that you'd like to become an NF accelerator, you will be hearing more from me. And then we have a brand new calendar of monthly NF2 meetups. So I've shared that in a couple of times, but please reach out to me if you haven't received it, and I'd be happy to share it. We are still finalizing our topic for the next meetup, which is on March 21st at 7 p.m. So mark your calendars. If you have suggestions for upcoming topics for future events, please let us know. We want to hear from you. We want to hear what you're interested in knowing about. And then, of course, I'm going to do a little plug for the NF Summit and the NF Conference, which are both coming up in June 21st to the 27th. They're back to back in Scottsdale, Arizona this year. The conference, I don't believe, has gone live for registration yet, but we'll be sending messaging out about that very soon. But the NF Summit, you can go to nfsummit.org for all of the information you need about that. Anything I forgot that you can think of, Michelle or Simon?
No, not at all. I think we've done a great job. It's been wonderful. I mean, I think we've all learned a lot.
Absolutely. Well,
Yes,
thank you
yes.
so much.
Thank you so
Dr.
much.
Chakravarthy, Dr. Adunka, and
Thank you for the
good to
opportunity.
everyone.